Mahesh has told me we have about 10 minutes for questions. Then we're going to quickly grab lunch, visit the exhibits for a few minutes, and then back for Dr. Bonatti's lunchtime lecture. So open the floor for any questions or comments or concerns. Oh, here they go. Oh, thank you. Doctor, what is your lower age limit for using percival valve? Well, I don't know. I know there's some geographical and some institutional and some healthcare system and country differences around the world. There clearly are, and some are quite rigid. I would say in California, Dan Bethencourt's here and a few others, for a long time, it's very rare that we would place a mechanical valve in even quite young patients unless they had a pre-existing mitral mechanical valve, or they're very young, say in their 20s and 30s. So I have certainly done tissue valves in the 40s in general. I have not put a percival valve in somebody under the age of 70, however, yet. But yeah, I think that at the time we'd like to have a little more durability data on that. Dr. Ruel, early on, what kind of trouble can you get into with your rat procedure? Just something unappealing about the rat.
Yeah. But is the mic on? Or?
Yes.
Microphone's on. This working? Yeah. I think if you follow those basic principles, you won't get into trouble. Obviously, not the first case to do as a young faculty out of practice, but it is very, very simple. And I think the key is to make sure that your box is at the right place, and make sure you're not too far from that annulus. And what I showed you is slightly different than what Joe Lamellis, for instance, would do. It works really well for him, but he's further away from the valve, and he's using his very carefully crafted instruments to expose and retract the aortic root in a way. With this, you don't need it, and you can do everything with your own hand tying. So follow that box principle. Make sure that you're venting well, that you retract your pericardium really where you need it, that you have a tape around the aorta. I think because if you were to leak from your prosnap, it would be an absolute disaster. That your aortotomy is done being very cognizant of how you're going to close it. And I think from there on, the rest is just a regular AVR. It's like a mitral valve repair. You know, there's this great expression that I tell or my trainees and colleagues, you don't start working on a mitral valve until you see it perfectly. And I think the same holds true of minimal invasive aortic valve replacement or any valve surgery. And that's why it's so much easier in a way than doing minimal invasive bypass. The problem with minimal invasive bypass is that you're working on 7 different exposures throughout your operation. You go from one to another, you take down the LETA, you do your proximals, you do the PDA, you do the OM2, etc. And there are all these different exposures. While with valve, you focus on one, and you can really dedicate the time to do that and not start clamping the aorta and opening your aortotomy until you know that you see it really, really well.
So I think you made the point, which is clear, they use a lot of clinical indicators of whether or not this is the right approach for minimally invasive surgery. So the patient, peripheral vascular disease, age, angina, et cetera. But I really concerned also that I made a point. There are some patients that have very vertical aortas, and a few of the times I've been in the right chest when I've had some struggles. And some of these technical tips that you brought up, I think, are key. But if they're very vertical and the aortotomy can get away from the other side if you don't have an oblique aortotomy, so that you can always make sure you see the left side of the aortotomy. And if there's any concern there, I put a locking knot, I put my pledgeted stitch in the end and then throw it off and do the aortic valve. Yeah. And so if you're going in without preoperative guidance, there's some suggestions you might need to make when you have a very vertical patient.
So actually, we encountered this too, and it's a very good point, Greg. And if you end up and you have what I call an aorta that's on the left, and it happens sometimes, there are a few things you can do. You can obviously stress all these exposure techniques, but the anesthesiologist is also there to help you. And that's where that double lumen tube helps you. And I've had a couple of cases like this where I asked Ben, who was a presenter at Grand Rounds this morning, Ben, let's work with the lung. And we actually have some data where we measure the distance between the annulus and the incision according to what my anesthesia colleague was doing. And we were able to bring it towards me by 2 centimeters. So that's not nothing. 2 centimeters when you're stuck and the aortic valve is away from you makes a huge difference. So I think there are things, and obviously we're all learning. And I'm not saying don't do a CT scan. It may be a very good idea. But ultimately, what I'm trying to say is you don't really need it. What matters is being so reproducible and organized that you can create the exposure that you need right there in real time if you are.
Yeah. And I think also with the concomitant procedures, I know Joe Lamelas has been quite ambitious in moving into aortic and even arch work through the right side. I personally feel it's a great challenge, and he's done thousands now of cases of AVR before he starts to edge away, whereas through the front you can pretty much handle it immediately and without many
that I
changes.
completely agree. I would never do an ascending aortic aneurysm this way. I don't think you can put the clamp as high as you would normally, and I think ultimately, the patient may be paying the price with disease that's left behind. It may look great at 30-day outcomes, but it may not look that great at 5 years. I completely agree with you. This is not an incision to do arch work. It's an incision to do an aortic valve replacement using any modality in a young patient who has a very long life expectancy and wants it done with low risk.
Right. All right, so we have a question now. Should I get a proctor for my first cases? Not sure who would pay for that. I'll take it from in the States. I know there are several vendors who have platforms, many of which are here today, and I know that they would be open and willing to bring in proctors. I've proctored for a couple of the companies already for mini mitrals and aortics. So that generally speaking, if you have I think a good opportunity perceived by the vendors that they're going to support you, they want to make sure the procedure goes well and that you buy their stuff. So that is available, and certainly any further questions on that, you can talk to us this afternoon. There are a lot of people out there with great experience that might be just be a friendly colleague to come and help you out as well.
Yeah,
Dr. Ruel.
I think that's a great point. Again, going back to the TAVR experience, everyone did 15 Proctor cases before you started, and that's an infinitely easier procedure than even a mixed AVR. So I think the concept of proctoring and helping each other towards this is crucial, and I think the companies hear that too, and whatever relationship you may have, we should not decry the importance of industry and surgical education. I think if you're a VAD surgeon, you know this, you cannot learn VADs without dealing with industry. It's impossible. Well, how are you're gonna find a non-Abbott or non-hardware / Medtronic funded meeting and learn about VADs? It won't happen. So we have to feel the same way about some of these operations, and I think industry is there to help us. And I've been a proctor with 2 different companies to help surgeons establish this, and it's important to do it.
Looks like you have a couple there.
No, I have not done any rat approach on redo cases. Again, I don't know if I would. I don't like complications. I don't like trouble, and I don't consider myself an experimental surgeon. I like when it's like a Swiss clock. So I'm sure you can do it. I've just never done it. So vertical aortotomy, that's interesting. I don't know what your thoughts. I've never done it. I would welcome anyone to comment on this. Danny, you seem to have a comment about it.
I've had a large right anterior thoracotomy experience, which was sort of a parallel learning curve to Joe's. I started without CT scans, just kind of figuring it out as I went along about 13 years ago. And so as a result of that, I do right anteriors on every isolated AVR, although I don't do ascending aortas, I don't do redos. Joe can and does, and he's comfortable with it. I just never have. But sometimes you find a calcified aorta with a challenging incision location, as we do from any approach, and then you have to figure out how to do that. And I've always been able to, I typically centrally cannulate as well, routinely, not 100%, but at 99%. But still, sometimes you find a situation where you need to adjust your approach, and you can make whatever kind of incision you need to, around the calcium, repair it, and get the procedure done. That, fortunately, usually comes from after a long experience, and it's helpful to have a CT scan to help you not do that in your first experiences.
Hopefully you never get in that situation. I mean, someone if someone's intermediate risk, they probably shouldn't get this with currently available. So these are low-risk patients, often bicuspid valve disease. Like, one challenge from this is that the extraction of the valve, as you know, the young, highly phenotypical bicuspid type of patients have very, very calcified. The calcium burden, they have Agatston scores of 6,000 or so. Yeah. So the removal of the valve can be more difficult, especially through a small approach. But I think if you end up in a situation where you've got a calcified descending aorta, something's gone wrong somewhere. Like there was some detective work that didn't happen there. From an exposure point of view, I have no experience whether a vertical would be. I've used it for calcified roots, but I don't know if that would be my first choice here.
Yeah, I think in the front it's fine, but the only time I would use it is in somebody with grafts on the aorta and you're just trying to be creative in your aortotomy, you know. Will durability guide patient selection for TAVR and SAVR in low-risk patients? So clearly yes. The low-risk trials, however, designed are at 2-year outcome endpoints with the opportunity to peak at 1 year and maybe even bypass the second year with annual follow-up for now 10 years. I don't know if for some of these institutions that are involved in the new trials, it's a 10-year follow-up. So it'll be a long time before we know. I think the most important admonition and acknowledgement this past year on surgical failure is that almost all of our data, no, not almost, all of our data is in structural failure and replacement rather than an echo endpoint for a surgical valve failure. And I think we need to compare apples to apples to look at durability. In all the trials for TAVR, we're looking at echo endpoints, not structural failure requiring reoperation or reintervention. So I think this is now kind of getting worked out. Last year there was a very controversial paper at EuroPCR on TAVR valves lasting 8.5 years, but again, those were echo endpoints, not freedom from reoperation for structural failure.
Greg, let me ask you the big question. Certainly, I don't have the answer. You might have it. You and Mike might have the answer. What do you think is going to be safest and have the best outcomes? TAVR in SAVR or TAVR in TAVR?
So valve in valve.
Valve in surgical valve
or valve.
Or valve in TAVR. In terms of, we're thinking low risk, patients with long life expectancy. Are you going to give them a SAVR first on the premise that TAVR and SAVR may have better outcomes in terms of perivalvular leak, et cetera, handling the calcium, having a better sitting for the valve? Mm-hmm. Or do you think that TAVR and TAVR is going to be as good and might as well start considering putting TAVRs as a first choice?
Yeah, that's a good question. I mean, I think that there's a lot of different things going on here. But first of all, even in the intermediate risk trials, the average age patient was only marginally lower than the high and extreme risk. Yeah. And what we're seeing already in the low risk trials is very difficult to get young patients because of the bicuspid prevalence in that younger population as well. So, it's going to be interesting, that kind of group in between. It's the patient under 80 who doesn't have bicuspid, who's low risk, are you going to operate on them first or go straight to TAVR with a trileaflet disease?
I'll ask you, why don't they have to have bicuspid? You've done, by mistakes, many people in this room have done bicuspid patients receiving TAVRs. Yeah. It's not the end of the world. It's not like the root explodes.
Well, I think we need to subgroup them a little bit, because Sievers 0, which is clearly a different population than the Sievers 1. We see lots of Sievers 1, the quote functional bicuspids, and in fact, when we look back in the partner and also at the core valve pivotal data, of about 10 to 15% had retrospectively bicuspid valves, which were supposed to be an exclusion. Mm-hmm. So there's going to be more data. There's a registry for the low-risk trial for bicuspids. There's some good data from Europe. I think that we're going to have a couple more trials. There's now a multi-institutional look at bicuspid results. They're primarily Sievers 1 in elderly. So I think that's very different than a 55-year-old bicuspid. I think it's hard to know where the needle will land, but I think we'll still be operating on people who are young with surgical valves, and again, they typically are bicuspid. They often have aortic pathology, and I don't know that the valves and the surgical valves. The challenge with that is, unless you have a 20 theory above, they can tend to constrain the valves. With the smaller TAVR valves, the gradients are fine. They don't. By the way, there is some durability data that smaller TAVR valves, kind of like surgical valves, don't have the same durability that the larger valves do, and gradient recurrent of low to mid-level gradients recur early in the smaller valves. So my gut feeling is you're probably better off with a very, very low gradient TAVR valve for TAVR and TAVR. But I don't think that will eventually get there, but I think there will be a transition where we'll still stay on the strategy of minimally invasive procedures with surgical valves with a planned in a 70-year-old, knowing that they're going to probably get a valve and surgical valve at some point. I think we're getting 10 minutes. Okay, so we're just slightly behind schedule. Thank you very much for your attention and some great questions.